If you have ever been told you have plaque in your arteries, the question that keeps you up at night is not, can I move one lab number a little? It is, can this process actually be slowed, stabilized, or in some cases, pushed in a better direction? That is the right place to start because plaque is not just a cholesterol story on a phone app, it is a long term artery story tied to risk, inflammation, plaque behavior, and what is happening inside the vessel wall over time. And that is why this comparison matters. Statins are not weak drugs. They are first line, evidence based therapy for many people at elevated cardiovascular risk, and more intensive LDL lowering, sometimes including PCSK9 inhibitors, has been linked with plaque stabilization and, in some settings, measurable regression of high risk plaque features. So, this is not a contest between medicine and some harmless wellness trend. It is a serious question about whether certain food-based strategies may influence parts of plaque biology that people do not see on a standard cholesterol panel. That distinction matters in real American life. A lot of adults over 50 are already taking atorvastatin or rosuvastatin, checking their LDL, and assuming that if the number improved, the whole problem is handled. But if the rest of the routine still looks like drive-through meals, late-night snacking, long hours sitting, poor sleep, high blood pressure, diabetes, smoking, or constant metabolic stress, then the artery environment may still be working against you. So the real question is not simply which options sound stronger. It is which tools are proven, which tools are promising, and which ones may be working through different mechanisms that actually matter for plaque. Here is what statins do extremely well. They can lower LDL cholesterol hard. High-intensity statin therapy is expected to reduce LDL-C by about 50% or more, which is one reason statins remain a foundation of cardiovascular prevention for people at elevated atherosclerotic risk. That part is real and it matters. But the next question is where many people get confused. A major drop in LDL does not mean plaque suddenly disappears on the same timeline. That is because blood work usually changes faster than artery structure. Your cholesterol panel may improve within weeks, but plaque stabilization or regression is typically evaluated over months and often much longer. A systematic review of statin-related plaque regression found that when regression was documented, it occurred on average after about 19.7 months, not after a quick before and after window. So if someone starts a statin, checks labs a month or two later, and assumes the artery wall has already transformed, that is usually not how this process works. This is where the source makes an important point, but pushes it too far. Yes, imaging changes in plaque can look modest in absolute size. In intensive statin trials, the visible changes are often measured in small volume or thickness shifts, not in some dramatic, the blockage vanished moment. But small imaging changes do not mean nothing meaningful happened. In studies like Reversal and Asteroid, intensive lipid lowering slowed progression and, in some settings, produced measurable regression of coronary atheroma burden. And even that still understates what statins are doing. Their benefit is not just about making one plaque measurement look smaller. Statins also help make plaque less dangerous by improving stability, including changes in lipid content, inflammatory activity, and fibrous cap features. So if you picture the disease process like a car, the first big win is often not the car disappeared. It is that the crash risk starts going down because the artery environment becomes more stable and less hostile. That matters in real American life because a lot of adults think in all or nothing terms. Either the scan looks dramatically better or the treatment must not be doing much. That is the wrong scoreboard. A statin may be doing something very important even when the plaque has not melted away on imaging. The honest takeaway is stronger than hype and more useful than disappointment. Statins often lower LDL powerfully, often slow or stop plaque progression, and in some patients can contribute to modest regression, but they are not magic plaque erasers on a short clock. Now, let's look at the first food signal the source brings up, pomegranate juice. This part is worth taking seriously, but it also needs much tighter framing than most internet versions give it. The strongest human signal did not come from casually eating more fruit in general. It came from a specific intervention, pomegranate juice, in a specific dose used consistently over time. In one small carotid stenosis study, patients drank 50 milliliters a day for up to a year, and the investigators reported progressive improvement in carotid intima media thickness, a plaque-related ultrasound marker. That is why the source emphasizes the juice and the small daily amount. But that same finding should be understood as an intriguing signal, not a blanket proof that a little pomegranate juice reverses plaque in the average person. That distinction matters because the evidence is mixed. The early positive carotid study was small and highly selective. A larger randomized double-blind trial in 289 adults at moderate cardiovascular risk used 240 milliliters of pomegranate juice daily for up to 18 months and did not find a significant overall effect on carotid intima media thickness progression, although some subgroups may have shown hints of benefit. So the medically honest conclusion is not pomegranate is proven to clear plaque. It is that pomegranate juice has shown a promising signal in some human vascular studies, but the result has not been consistently replicated in larger controlled settings. Where pomegranate gets genuinely interesting is mechanism. Atherosclerosis is not driven only by how much LDL is in the bloodstream. It is also influenced by what happens to that LDL after it circulates, especially when oxidative stress is high. Small human and mechanistic studies have suggested that pomegranate juice can reduce LDL oxidative susceptibility and improve paraoxinase 1 related activity, a pathway linked to HDL-associated antioxidant function. That does not mean oxidized LDL is basically eliminated, and it does not mean one juice can shut down plaque formation by itself. But it does mean pomegranate appears to affect biological pathways that matter in plaque development, especially oxidative stress and lipoprotein behavior. That is a useful point for a US audience because many adults are looking at the wrong scoreboard. They see an LDL number on a lab portal and think that is the whole story. But plaque biology is shaped by the entire artery environment: smoking, diabetes, blood pressure, visceral fat, long stretches of sitting, ultra-processed food patterns, poor sleep, and chronic metabolic stress all make oxidation and endothelial damage more likely. In that setting, a food that favorably influences oxidative processes may be worth attention, but it should be understood as a possible support tool inside a bigger risk reduction strategy, not as a replacement for proven treatment. So, the strong version of this section is not that pomegranate juice trumps statins. That claim goes beyond the evidence. The stronger and more useful takeaway is this: pomegranate juice is biologically interesting because it may work on parts of plaque biology that standard lipid numbers do not fully capture, and small human studies have reported encouraging vascular signals. But the total evidence remains mixed. The best findings came from limited populations, and none of that justifies treating pomegranate juice as superior to guideline-based cardiovascular care. It is best thought of as a plausible adjunct with an interesting mechanism, not a proven substitute. That is a much more trustworthy place to stand. The second intervention in the source is nattokinase, and this is where dose and study design matter a lot. Nattokinase is an enzyme derived from natto, the traditional Japanese fermented soybean food. It is interesting because it is not being pitched as another LDL-lowering drug. It is being discussed for a different lane of vascular biology: fibrinolysis and thrombosis-related pathways. But right away, the source makes one useful distinction that needs to stay in the script. The evidence people quote is not really about casually eating a little natto. The headline study used 10,800 fibrinolytic units a day for 12 months, which is a supplement-style exposure, not a normal food-level habit. That study is the main reason nattokinase gets so much attention online. It was a large retrospective clinical study involving 1,062 participants, and the authors reported significant reductions in carotid intima media thickness and carotid plaque size at the high dose, along with improved lipid measures. They also reported that 3,600 FU per day was ineffective, and they described the high dose as well tolerated in their data set. That is a real signal, and it is stronger than the kind of tiny pilot study supplement marketing often relies on. But it is still not the same thing as a randomized, placebo-controlled plaque reversal trial. The authors themselves note that lifestyle factors and co-use of vitamin K2 and aspirin were associated with better outcomes, which means the result cannot be treated as clean proof that nattokinase alone was responsible for every bit of the observed benefit. And that limitation becomes much more important when you compare it with a more rigorous trial. In the nattokinase atherothrombotic prevention study, a randomized double-blind trial, 265 low-risk adults with a median age of 65.3 years were assigned to 2,000 FU daily or placebo and followed for a median of 3 years. The result was a null finding. Nattokinase did not significantly change carotid intima media thickness, carotid arterial stiffness, blood pressure, or the measured lab markers compared with placebo. So the evidence does not support a simple blanket statement like nattokinase reverses plaque. The more accurate takeaway is narrower. There is an interesting high-dose observational signal, but lower-dose randomized evidence in healthier adults did not reproduce it. Mechanistically, nattokinase is still worth understanding because it does appear to act on a pathway that is different from statins. Human and mechanistic work supports that nattokinase has fibrinolytic activity. It can directly cleave cross-linked fibrin, and studies describe effects on related pathways involving tissue plasminogen activator inhibitor 1, and other coagulation or fibrinolysis markers. A small placebo-controlled crossover study in healthy men found that a single 2,000 FU dose changed several coagulation and fibrinolysis parameters within hours, including fibrin/fibrinogen degradation products and factor VIII activity, though the changes stayed within the normal range. That helps explain why nattokinase keeps showing up in circulation discussions. But this is exactly where the source overstates the mechanism. It is too simplistic to say plaque is basically a fibrin network that nattokinase makes collapse so cholesterol can come out. Atherosclerotic plaque is far more complicated than that. It involves ApoB-containing lipoproteins, endothelial dysfunction, inflammation, smooth muscle cells, fibrous cap biology, calcification, and sometimes superimposed clotting. So the strongest supportable version is this. Nattokinase may influence the clotting side and fibrinolysis side environment around vascular disease, and high-dose observational data suggest it may be associated with improvement in plaque-related carotid measures. That is very different from saying it has been conclusively proven to dissolve plaque the way a drain cleaner clears a pipe. And for a US audience, one more point matters. Because nattokinase has anticoagulant and fibrinolytic effects, the phrase "no side effects" cannot be treated as a universal conclusion. The high-dose observational study reported no noticeable adverse effects, but the broader literature includes bleeding-related case reports and a case of a patient who substituted nattokinase for warfarin after mechanical valve replacement and later developed valve thrombosis. That does not prove nattokinase is broadly dangerous. It does mean people should not treat it like a harmless food add-on, especially if they are already taking aspirin, apixaban, rivaroxaban, warfarin, or other blood-thinning therapy. The strongest takeaway is not hype, it is discipline. Nattokinase is biologically active, dose-dependent, and potentially meaningful, but the current plaque evidence is still not strong enough to place it in the same evidence class as standard cardiovascular treatment. This is the larger idea the source is really trying to reach, and it is the most useful part of the whole argument. Plaque is not just an LDL story. LDL still matters enormously, and lowering ApoB containing lipoproteins remains one of the most evidence based ways to reduce cardiovascular risk. But arteries are also affected by blood pressure, smoking, diabetes, endothelial injury, inflammation, inactivity, excess body fat, and the kind of daily routine that keeps stressing the vessel wall. That is why one improved cholesterol result does not automatically mean the whole disease process is under control. That is also why the source keeps pushing a multi-step model instead of a one-step fix. Pomegranate is being discussed because it may influence oxidative stress and some HDL-associated functions. Nattokinase is being discussed because it may affect fibrin-related and fibrinolytic pathways. Those are different lanes of vascular biology. That part is useful because it helps the viewer stop thinking in one-number terms. The artery does not just see LDL. It sees the full environment you create around it every day. That includes the food pattern, movement pattern, sleep pattern, glucose pattern, and pressure pattern the vessel wall is exposed to week after week, year after year in real life. So the strongest version of this message is not, take this exact stack and plaque will be gone in 3 months. That goes far beyond what the evidence can support. The stronger message is that plaque does not always move in only one direction forever. When the artery environment improves broadly enough, the process may be slowed, stabilized, and in some settings, partly regressed. But that usually comes from comprehensive risk reduction, not from one miracle food, one supplement, or one dramatic anecdote. And that is where lifestyle modification becomes concrete. In real American life, it means the artery is living inside your actual routine. Drive-through meals, desk-bound days, short sleep, uncontrolled blood pressure, high blood sugar, smoking, and heavy reliance on ultra-processed food. Drugs can help. Diet can help. But the deeper goal is to remove as many plaque-driving conditions as possible at the same time. That is the takeaway worth keeping. Not that one intervention beats everything else, but that arteries improve most when you stop feeding the process from multiple directions. If there is one practical takeaway to keep from this whole discussion, it is this. Stop thinking in 30-day miracle terms and start thinking in 1 year and 5-year terms. Atherosclerosis is built over time, and the conditions that feed it are built over time too. High blood pressure, high blood sugar, smoking, inactivity, poor diet, excess weight, and chronic metabolic stress. When those drivers improve consistently, the artery environment usually improves with them. That does not mean anyone can promise you that plaque will vanish or that one supplement stack can prevent every future event. The medically honest goal is stronger than hype and more useful than false certainty. Lower the conditions that make plaque grow, become unstable, and raise cardiovascular risk. In some people, that means medication plus lifestyle change. In others, it means much tighter control of blood pressure, glucose, smoking, sleep, and diet patterns that have been quietly pushing risk upward for years. And the reason this matters is not abstract. Heart disease remains the leading cause of death in the United States. So the real win is not chasing a dramatic headline about clearing arteries fast. The real win is building a routine that makes your arteries less exposed to the same damage tomorrow, next year, and 5 years from now. That is how you shift the odds in your favor. If this changed the way you think about plaque, then do not leave this as just another video you watched and forgot. Take one hard look at the routine your arteries are living in every day and start fixing the part that is hurting you most. And if you want more clear, evidence-based breakdowns that help you understand what really drives heart risk after 50, subscribe now and stay with this channel. Then comment arteries below if you are ready to start changing the conditions that shape your future.